Hello everyone, this is Chris. I'm gonna do my article on cardiac rehabilitation, physical activity, and the effectiveness of activity monitoring devices on cardiovascular patients, an umbrella review of systematic reviews. The research phase is the first one, which is the benefits of physical activity on cardiovascular disease in my case. For the research area, it is cardiovascular disease and how physical activities can help reduce and help affected populations. This is the citation over here. And most of the authors are affiliated with the Warby Center for Evidence in Health, and almost all of them are affiliated with Flinders University and Caring Future Institute, all in Australia. This is the journal that the article is published in. It's called the European Heart Journal for Quality of Care and Clinical Outcomes. It has a impact factor of about 4.6 in 2024. I know this is different here, but I believe this is the most recent one. And for any merits, all I could find was it is the official international peer-reviewed journal of the European Society of Cardiology, dedicated to outcomes research, and the journal also has a close alliance of the European Heart Health Institute. Here's a picture of what it looks like. For a quick introduction to the article is an umbrella view that looks at how cardiac rehabilitation CR programs that use devices for monitoring physical activity compared to ones without in terms of physical, clinical, and behavioral outcomes. Use of activity monitoring devices in CR was associated with statistically significant improvements. These include increased physical activity, more overall activity levels, less sedentary time, and also reductions in rehospitalization due to secondary attacks, most common in heart failure. The purpose of the article is to consolidate the evidence on the effectiveness of activity monitoring devices in their application on physical activity and health outcomes of patients with cardiovascular disease who attended CR programs. Included in this evidence are systematic reviews and meta-analysis of randomized controlled trials. It was also used to compare CR programs that included such devices or apps versus those without, especially looking at effects on physical activity, clinical outcomes, and behavior changes, mainly to inform practice and possibly guide integration of activity monitors into CRs. As for the method section, the general study design is an umbrella review following JBI guidelines. They have registered their protocol on the Prospero and published it in JBI Evidence Synthesis, where they go over all their different methods of how they screen, assessed, reviewed, and extracted. The reporting standards, they follow the PRISMA guidelines for reporting. I have a chart on the next slide. The databases they did a comprehensive search up until the 9th of February in 2022 in Medline, Embase, Sportdicus, Cochrane, Scopius, and all these other different databases, Web of Science also being one of them. But they mainly did for English-speaking publications. For the screening process, they imported into JBI summarized systems for screening, assessment, and review. The primary outcomes they're looking for was anything to do with physical activity, measures from devices or apps, such as these examples given. For secondary outcomes, they were obviously looking for clinical outcomes, whether it's mortality or any of these cardiovascular diseases, such as infarction, stroke, revascularizations. For quality assessment, they had 2 independent reviews assess methodological quality of which were included in the systematic reviews in JBI Summary, which is the tool. For data extraction, they also had 2 independent reviewers use the standard JBI data extraction tool, and they extracted all these different characteristics, very common to other researchers. For data synthesis, they collected data from 5 different meta-analyses across, including the reviews, and they extracted effect sizes, CIs, heterogeneity, chi-square, degrees of freedom, and Z-scores when they were available. Here is the chart for the PRISMA flow diagram of their search and study selection process. As you can see, when they were looking for these new studies, this is how they found it. And then when they screened and assessed, eventually they did come to, I think, about 9 is what was included in this article. And they did exclude a lot, whether it was duplications, like up here, or they couldn't find the article, or it just didn't match criteria, stuff like that. And this is the Prisma flow diagram that they mentioned in their methods section. And this is their ultimate result, which was, I think, 9. These are all the included studies here. Again, there were 9 from the previous slide. And I thought they did a really good job with this chart because they show how well, again, the quality of evidence of all these designs, and they gave it a rank. As you can see, there's 2 that are pretty bad, but all the other ones are pretty mediocre or good, including to their criteria. On another note, when I was going through the supplementary materials, I did find a lot of the excluded stuff. As you see, they excluded a total of 27 excluded studies. I'm not going to spend too much time on this section, but as you can see, either they didn't meet criteria, they couldn't find it, or just a duplicate paper from something they already had. For the results section, as you can see, for the physical activity, devices with apps and CR led to small, moderate increases in activity and a significant reduction in sedentary time, though results did vary, and heterogeneity was often very high, which is not good to see, because that means it was very inconsistent across studies. For clinical outcomes, trends did go towards improved cardiovascular risk factors, so such as BP, cholesterol, BMI, and aerobic capacity, but effect sizes were generally small, and sometimes they just weren't clinically significant. For behavior outcomes, they were mixed but generally positive, so lower smoking, better diets, lower alcohol, with one review showing better quality of life, which is nice to see. For overall, I think the evidence supports a modest benefit of using devices and apps in cardiac rehabilitation, but variability across studies limit firm conclusions. Here's the first figure they provided. There's not much to say for this one, other than the fact that there were lower blood pressure of the use of activity monitoring and higher aerobic capacity, which is nice to see. Obviously, this is higher homogeneity, but it's nice to see the higher aerobic capacity here. This graph is a little better than the last one. As you can see, there's lower physical inactivity with the use of the monitoring. There's high I2 though, which is not nice to see. That means it's inconsistent. But this rehospitalization lower is very nice to see because that's lower heart failure rehabilitation, that's lower any secondary attacks, and it's very high heterogeneity. Other than that, something interestingly, there's this lower diary intake and healthy intake, which is not good to see. And that wasn't really mentioned, but I thought that was interesting. This is the one I was talking about before, which generally I think has the best graph they have. As you can see, physical activity and step count, which is their aerobic capacity. I know it's also down here, but this is what they said it was for the physical outcome section. It is higher. It is nice to see. Even the heterogeneity is pretty good here, which means lower risk factors for cardiovascular disease. As mentioned before, all of these were generally trended towards negative, with the LDL low and the total cholesterol significant as well, which will help prevent cardiovascular disease in the future with monitoring. In conclusion, activity monitoring devices and apps improved physical activity and aerobic capacity in CRs. Some positive changes in behavior and small improvements in clinical outcomes were also very seen, which is nice to see. As mentioned before, effects are often modest and not clinically significant, especially versus like blood pressure and cholesterol. So even though I mentioned that it was generally a negative trend, as you see, a lot of them did cross the 0 to 1, and so it wasn't significant, or the changes just wasn't as big as people thought. Evidence is mostly short-term, which is very bad to see, and long-term effectiveness does remain unclear. Connecting to other similar phrases, similar research results to other umbrella reviews, modest improvements in activity and outcome across populations, even with different measurement methods. Supports earlier CR and tele-rehabilitation studies that show technology can boost engagement and exercise intensity. Hides a gap for future trials, however, with few studies directly comparing CR with devices versus CR without devices, which is bad. So it's a bad comparison in general. Applicable practical applications, integration into tele-rehabilitation and home-based CR to improve accessibility and cost effectiveness. used for monitoring physical activity, intensity, and behaviors as part of routine CR programs, just normally. And obviously, making sure that you get all the kinks out with the privacy and the data, how to handle it before implementation, so more work isn't added. More conclusion strength. I think the study is pretty good. As a systematic search of moderate high quality reviews, there's consistent trends across studies despite varying metrics, and it provides broad overview across physical behavior and clinical outcomes. I generally just wanted the clinical outcomes, but since I got these two as well, it was nice to see. Some weaknesses, obviously, short duration. It's 1 to 6 months. It was not that long. Cardiovascular disease is a very long-term thing, and I would like to see more. It's inconsistent with its measurement methods. A lot of it was objective, or it was self-report. This objective was like the actual like labs, and the self-reports obviously what you actually feel. Obviously, it's very varied in device types and interventions. There's few direct comparisons between CR versus without, which is very hard to like actually see and compare correctly. But it kind of worked where they had, and possible overestimation of effects due to control group selections. For future studies, the author's take is need longer term conduct academic evaluations to see if it's very cost effective overall to even provide everybody with these devices, compare different devices head to head, and focus on implementation research to make sure when these are implemented, there's not extra burdens on the system and more problems. My personal take, I agree. The long-term studies is probably would be really helpful. Obviously, we have programs going on right now, like the Honolulu Heart Program, and that's been following people. And it'd be great to see a study or analysis of long-term effects. And I think they should also take in consideration just the daily life of the person, whether it's just what they do in the study. And thank you for listening.